So webinar is now live. That's when I can stop talking properly. And I just have to make sure we are streaming where we need to be streaming. So give me 1 second, everybody. Welcome to the broadcast. Those of you who are popping in at this point, we have 39 participants in the room. So sorry we're a little late, guys. Just trying to get us to stream on Facebook. So we have, you're seeing a screen share right now. I'm going to stop that because I'm having a hard time checking on some technical issues. I think, can somebody confirm if we're on Facebook at this point, if we're streaming? It says we are, but I didn't go through the rest of the steps. No? Okay. Ladies and gentlemen, just give me 1 moment because we're going to simulcast through Facebook and we want to make sure everybody can watch. So just give us 1 minute to do some technical figuring out back here, and we'll be starting the program shortly. Unfortunately, there appears to be a glitch with Facebook today, and I do not know that we will be able to go live from Facebook. So alternatively, I'm going to just go over to Facebook and tell everybody how they can join us live if they need to right now. It will be posted onto Facebook later. We had technical difficulty streaming today, but we are live at this link. Okay, so we will post after the event on Facebook, and we are just gonna get ourselves going here. And Roselle is now joined the group. Okay, so we had a little technical difficulty on the other coast as well. So now we have fixed the technical difficulties and we are all here together. So welcome everybody. An attendee has their hand up, but we're not taking questions quite yet. So please bear with us. Welcome to this episode of the Bighearted Warriors Tour, brought to you by the Hypertrophic Cardiomyopathy Association. And today we are joined by our wonderful team at UCSF, and the HCMA staff is also here today. So before we move to the West Coast, let me tell you who helps make all of this happen for you. And they're going to signify who they are by not only their names beneath them, but a wave. First we have, and I'm going on the order you're on my screen, ladies. Valerie Ventry is our Center of Excellence Coordinator. So she helps us develop and maintain our Center of Excellence networks. Amy Mann is our meeting coordinator, and she is responsible for helping make sure that these meetings actually happen. And last but not least, in the Brady Bunch Alice box on my screen, is Julie Russo, who is our volunteer coordinator, who you will be communicating with a lot more in the future as we roll out some of the programs I'm about to discuss with you. So Ted, Catherine, and the other Julie, could you please unmute your mics and just tell everybody hi, what your role in this program is going to be, and then we're going to get started with my talk, and then we'll bounce it back.
Hi, I'm Roselle Abraham, and I'm the director of the UCSF Center of Excellence, HCM Center of Excellence. And we work as a team here with Ted, Kate, Hazel, and several of our colleagues in EP, heart failure,
labor and delivery,
genetics,
radiology.
We
cover it all.
You do. Okay. Julie, want to say hi?
I'm Julianne. I'm a genetic counselor and work with the team. And we have 2 of us and 1 in pediatric cardiology to serve our patients and their genetics needs.
And Ted, you're on mute. Still on mute.
Hi, guys. Ted Abraham, wonderful to be here with Lisa and the crowd. Remember, Lisa, this whole journey started with you and HCMA, so we're proud and delighted with this 20-year relationship with the HCMA, and that's the reason we're here and feed off your dedication and energy. Great to be here.
Thank you so much for being here. But I think, you know, given our relationship, there has to be a backstory given. And I'll give my perspective, you give yours. So I was at the American College of Cardiology conference, early 2000s. And this woman comes to the booth and starts explaining that, you know, she's just finishing up with her program at Mayo, and her husband's this imaging guy at Mayo. He's done a little work in HCM. She likes genetics and EP, and they really want to be involved with HCM. Where could they go? And I'm like, I got a map. Where do you want to be? And they gave me a couple of centers that they were looking at to match at. And I said, you know, at that point, we really needed something around the DC area, and Hopkins was on their list. So I'm like, that would work really well for us. And as I say, the rest is history, and it's evolved since then and moved on. And now they're at UCSF, which we really needed another program on the West Coast. So their timing in the HCMA's life cycle has been fantastic. And that's how I remember it. What about you guys?
Oh yes, so I was that person. So I was finishing fellowship, and I came to, and I really wanted to work on hypertrophic cardiomyopathy. I was obsessed with working on hypertrophic cardiomyopathy. And during my training, I had seen a lot of patients, but I really wanted to do something on my own when I finished my fellowship. And I went and I saw this booth that said HCMA. I said, wow, there was even an organization. Maybe I can work with them. Maybe they can help me. And so then I went and I met Lisa, and I was so excited. I thought, wow, I can actually do something on my own, probably. But of course, I couldn't do it all on my own because I'm not an imaging person, and echo is the main, is sort of the, you know, the basic diagnosis. And so then I convinced Ted. It took me a while to convince Ted that HCM was an important disease that he should focus on. And then once I convinced Ted that he should be working on HCM, and then we were able to set up the center. And so I had moved, when I finished my fellowship at Mayo, I moved to Hopkins. And that's when I talked to my chief of cardiology, and I said, you know, I really want to start an HCM program. And I met this lady, and she told me that it was possible. And so I think the rest is history. And then he was able to convince Ted to move from Mayo to Hopkins and start the whole program.
Roselle, I think you got to be a pretty persuasive lady to make some of those changes in the world and in your own family. So you are one of two couples running an HCM program in the United States, which is unique in and of itself. But I think it's really smart that you tend to work off of different campuses. Okay, so ladies and gentlemen, I'm going to launch a poll now. And over the next few minutes, while I'm rattling on about all things HCMA, I'm going to ask you to participate in that poll, which should have populated now. Some of the older versions, if you haven't updated your Zoom, you might not see the poll, but you can jump in and take the poll at any time while I'm talking. I think you can multitask. I think that's good. So I'm going to ask all of our panelists to put themselves on mute, and I'm going to do a screen share, and I'm going to kick us off today with a talk a little bit about the Hypertrophic Cardiomyopathy Association and what exactly it is that we're trying to achieve in some of the projects that you and your family can get involved with. So number one, a little bit of housekeeping work as we start the day. So we are, as I said, at UCSF today in spirit because COVID keeps us where we are. As many of you may know, we were planning to be in San Francisco in March, a week before the world got shut down. So you were supposed to be the second one of the year, and instead now here we are in October getting this done. Oops, here we go. So today we are going to hear from yours truly, and we're running a little bit late, so I'm going to try to, I might run through some slides. If I miss something, you can go hear another talk, which is going to be up online, and you can catch the stuff that I'm going to kind of go fast through today. So we're going to have myself, and then we're going to have Roselle talk about putting out the fire in HCM, new research, from physiology to programming stem cells. This is going to be a really cool talk, and for anybody who has been following the tour, this is going to be different than anything you've heard yet. And then we're going to hear from Catherine, their nurse practitioner, on the UCSF experience, what patients experience when they come in, what the process is, and how they manage patients. And Julianne is going to talk to us about genetics, which we have not heard much about in the HCM Bighearted tour yet. We hear a little bit about it, but we're going to take a deeper dive. And then we're going to talk about emerging therapies. You all are following the news of the week with another San Francisco firm, Myocardia, who was just went into a deal with Bristol Myers Squibb. And for those who aren't aware of who they are, they're one of our sponsors, and they have a drug in trial called mavacamten that is currently under review and will be probably presented to the FDA later this year. So Ted's going to talk about that. I want to take a moment to thank our sponsors of this program, Myocardia, Cytokinetics, Boston Scientific, and Invitae, for their generous support, which of a tour that was supposed to be in person, and they've been great partners as they've allowed us to reimagine what patient education is, and here we are today having this conversation because of their support. I will tell you a programming note. At the conclusion of this session, you will be able to ask Q&A in the webinar. This webinar is being recorded, and oops, a daisy. Let me just make sure that are we recording, guys? I think yes, we're recording to the cloud. Just making sure, because we normally stream through Facebook as well, and now we're gonna have to upload to Facebook. I may try to get that working later. But we're going to do Q&A here, but that's more public because this presentation will go to the website, go to YouTube, and be visual elsewhere. So if you want to ask questions and you want to do it in a private way, we will be opening a meeting room after the webinar closes, and you will get a link towards the end of the webinar where you can come join us and ask personal questions in that group while there are other individuals there, and we cannot guarantee your PHI, that you're sharing the information freely. It will not be recorded and it will not be shared to the world on the internet. So that's just a programming note. Okay, so let's get into HCM, and I'm going to breeze through these slides really quick. A lot of you have already endured a lifetime of misdiagnosis, mismanagement, and misunderstanding. You were told you had asthma, panic attacks, anxiety attacks, mitral valve prolapse, innocent murmurs, when in reality you had HCM. And we're getting better at finding HCM in the medical system. We're not quite where we want to be yet, but there are some endeavors underway to look at your electronic medical record system, find the things that are consistent with HCM, and hopefully help more people get to diagnosis faster. So this is a big job, and when you look at the numbers, we've got a lot of work to do here. But we're going to work on a couple of ways to help with identification outside of the clinic, and we're going to talk more about that later. But let's talk about HCM. You were always told, or you probably heard at this point if you're in this webinar, that HCM affects 1 in 500 people. Reality is it's probably more than that, because that data originally came from echo data from the 80s. And reading an echo in the 80s is kind of like looking at a TV from the 70s versus HD TV today. So we get a clearer image with the newer technologies. That's number one. Number two, we have MRI. Number three, we have genetics. So now we can look for the asymptomatics and find them through genetics. We can look for those who are clinically identifiable but not really having symptoms within a family, and we can see them better and faster, which means our 1 in 500 isn't 1 in 500. It's probably closer to 1 in 200-ish. There's still some debate on that number. It's a soft number. But the problem is there's somewhere between 750,000 and 1 million Americans who have diagnosable HCM at this time. However, only about 120,000 of them are in clinical care for their HCM, which means there's a huge undiagnosed population out there. So consider yourself lucky to have gotten to the diagnosis so that you can identify what you need to do individually. But there's a lot of other people out there that need this message, and we're going to hopefully get to them. So we want to make sure that we're talking about the same disease, and I'm going to go through this one really fast because you got some great geneticists here today, and they're going to talk to you about this. So HCM is typically thought of as a disease of the cardiac sarcomere, and there's 13 plus minus genes that are associated with 3,000 plus minus mutations that we know cause HCM. But then there's this group that doesn't have an identifiable gene mutation, but everything in them acts like sarcomeric HCM. And then you have the non-sarcomeric HCMs, which might have different treatment pathways and different disease courses, maybe associated with a syndrome. These are only a couple of examples of what some of those might be. AMP kinase, LAMP2 mutation, which is Danon disease, or Fabry's disease, which is GLA mutation. There are others, Noonan syndrome, Costello syndrome, Leopard syndrome. There are other syndromes, but the feature of HCM is treated similarly in some and very different in others. So it's really important to know what we're talking about. So in HCM, there are pathways, and every one of our centers of excellence has expertise in all of the pathways of HCM. That's how they become a center of excellence. But when you're dealing with a community-based cardiologist who doesn't see an awful lot of HCM, these pathways can be a little difficult to discern from one another. And in fact, patients can be in 2 or 3 different pathways simultaneously. So either you're asymptomatic or told you have HCM and you're at low risk, or maybe you just are gene positive. That has one trajectory, and it's follow-up. And just because you're asymptomatic doesn't mean you're low risk for sudden death. So we have to balance those to make sure that you've gotten all the right evaluations. We've got our sudden cardiac arrest or sudden death pathway, which we protect with defibrillators. Progressive heart failure with obstruction, we have a lot of tools for that now. Alcohol self-delusion, myectomy, medication, maybe this new trial drug. Advanced heart failure, low ejection fraction, stiff hearts, there's drugs, there's devices, there's transplant. Atrial fibrillation can lead to stroke, and we have to manage that carefully with anticoagulation and possibly ablation, possibly cardioversions. There's a number of pathways there. So if you're seeing a community-based cardiologist and you've not been seen by a center of excellence physician yet, you're probably in a situation, if your cardiology practice is average, that average population is about 2,000 patients per year that they see in their entire practice. This slide comes to us courtesy of the American College of Cardiology. So that means by statistical standpoint, your average cardiologist might see 10 patients with HCM. And considering their pathways can be so diverse, it's very difficult to know how much experience any community-based cardiologist has in any particular phenotype or symptomology related to HCM. So that is why we created the HCMA Recognized Center of Excellence concept, which really started in the late 90s. We did a talk last night with NYU, and Mark Sherrod was one of the original HCM programs in the country when I started this 25 years ago. And at the beginning, there was like 5 programs till like somebody like Roselle pops up on my trade show booth, which is, by the way, where I've recruited most HCM Center of Excellence directors, which makes me really hate that we can't be out there on the floor of AHA this year, finding new young minds that are interested in HCM. So the concept has grown, and it's evolved to 41 centers of excellence as of this month. 2 of them are going to be launched. One's a relaunch because it's an addition to an existing program. But we're happy to welcome Houston aboard to the HCMA family. And we're really proud of the program in Orlando at Advent, where they have expanded and provided more services than they'd ever had before for patients with HCM. So there's a full directory listing at 4hcm.org. You can go there and find a center of excellence that's convenient to you. We have a number of programs under review right now. There are about 8 of them. Valerie, we got to update my gray dots on here. I think I missed 1 or 2. So we've got a lot of work to do, and we're trying to figure out how to bring these programs on virtually, which is very difficult for us. So we may do soft launches on some of them, but stay tuned for that. So what is a center of excellence, and how does a patient get care? Here you see on the screen in front of you 2 HCMologists. And HCMologist is just our cute word for a HCMA center director. You can thank Harry Lever at the Cleveland Clinic for coining the phrase HCMologist. And your HCMologist is kind of your gatekeeper. And all the patients will come to the HCMologist because they've been diagnosed with HCM. But they will go through imaging and electrophysiology evaluations, heart failure, genetic testing, mental health evaluations. And at different points in their life, they're going to land in different buckets. And from those different buckets, they might have some services performed. But obviously, maternal fetal medicine is not going to keep that patient with HCM. They're going to send them back. But other times, when they go to advanced heart failure, the patient may stay there and go to transplant from there. But the majority of patients come right on back to the top and come back under the care of the Center of Excellence coordinator. One of the reasons for this, and one of the probably most important reasons to me anyway, is a lot of times patients with HCM can land in electrophysiology. And with all due respect to our electrophysiologists out there, sometimes they miss advanced HCM muscle disease because they're so focused on rhythm. That's why the HCM Center of Excellence director is probably the best person to take that step back and assess what team member needs to be deployed at what time for what patient. So there's going to be a new document published very, very soon by the American College of Cardiology and the AHA. And it's going to be an update on the 2011 guidelines for the treatment and management of HCM, which also has an interesting history that I'll talk about some other day. But they're going to use the HCMA's modeling to go out and make a very public statement about what a comprehensive HCM center is, what a primary is, and what the role of a primary cardiologist in your community is. Now, I've battled with this terminology for a long time on comprehensive, primary. I will tell you that every center of excellence is not created equal, and not all have the same level of skill and ability or patient volume. And the ones with the largest volume tend to have the most comprehensive service models available and can handle everything from maternal fetal medicine, diagnosis, management of HCM, and all the way to transplant under one roof. And that's pretty amazing. And probably about 25% of our centers fit that model. A lot of the other ones are what we would refer to now as primary centers. They may refer out for surgery. They may refer you someplace else for transplant. They may work with your maternal fetal medicine doc outside of a different hospital. And that program can work really well too and provide a great service to the HCM community. Your primary cardiologist still holds an important role because they're the one in your community. If you have a new onset of a symptom and you can't run to your center of excellence, you know you have a safety net with your hometown cardiologist. You can do some of your testing with your hometown. Some of them are better done at a center of excellence. So there's a lot of people that can be involved in the care model, and it's really important to understand the role of each one. So what happens when a patient with HCM goes to an HCMA recognized center of excellence? We've surveyed you, we've listened to you, we've tried to advance the therapies and the services available in each center. But what we know from you is that you feel heard. You feel physically and emotionally more in control of your life. Your outcomes are better from invasive procedures. They have lower complication rates. You have the ability to participate in clinical trials and learn about cutting edge information, not 3 or 4 years down the line, but as it's happening. So that's an amazing thing that you can participate in. We also, that's a duplicate slide. Although there's something on here that I don't know why I gotta fix that slide. Patients who are treated first at a community cardiologist who doesn't know HCM much, when they go to a center of excellence, they are often found to be on medications that are contraindicated or not optimal for their HCM. So we normally get them off of the bad meds and the bad therapies and onto the right ones. So I'm going to talk really quickly about some of the ways that the HCMA is here to support you. As you all know, we have a Facebook page and some active Facebook communities, and they are going to be growing. And hopefully over the next 2 to 3 years, you're going to see something pop up called HCMAI, which is our international partner patient organizations. So I'm on the hunt right now, kind of like I was on the hunt for like Roselle and Ted back in the day. I'm on the hunt for patients like us from around the world who want to be the hub and spoke for their HCM communities in their country. So that we're going to be reaching out to them. They will have a page that's linked to the HCMA Facebook page, and it'll grow out from there. Right now, we have our parents and communication network and our general HCM community. We did change our art slightly, but it's generally the same feel with a phone number and a place that could be better read on the new optimized Facebook. We're also on Twitter and we're on Instagram. So we have a big social media platform, LinkedIn for the professional groups. We're building out our HCMA online support group system. Hopefully we will do some more in-person events as the current situations allow. But we have trained 14 people, about 80% through the training process. We have some sessions next week to finish that up and to start launching these online support groups. It's probably going to be a little bouncy in the beginning as to how they're going to structure. Some of them will be based on topics. I will be doing once a month pre-myectomy or considering myectomy groups for those of you who are pipelined towards that treatment. We will be doing a teenager to 25-year-old group. We will be doing some regional groups so you can feel heard and you can commiserate with your HCM brethren. We've had a big call for groups for family members to understand what it's like to live with HCM from somebody that they're not living with, because they're not being heard in the way that they want to be. So that will be coming up. We will, once that gets launched, you're going to start seeing other programs being launched. And one of them is going to be the peer-to-peer Bighearted Friends Network. For those of you who've known me a long time, and this week I was able to speak to somebody that we originally spoke in 1997, so it's been going on a long time. I remember a lot of people, and we haven't been able to create an infrastructure so that we can link them together in a coherent manner because technology didn't catch up with us yet. But now I want you to think of us as the eHarmony of HCM peer-to-peer support. You'll be doing surveys, and we're going to do survey-based linkage and look for the best models and let you know who we might link you up with as a peer. It may last a day, a week, a month, a year, a lifetime as a peer-to-peer, but you can be a mentor peer or a mentee peer. You'll be able to pick where you are and what you're looking for. You can be a mentor and a mentee. You can have somebody supporting you while you're supporting somebody else. So that program will roll out hopefully it will be pretty well organized by the end of first quarter 2021. You can participate in our Share Your Story program. And in that program, we're doing an amazing call out to help with our brand new, newly designed 2021 website. It's going to be torn down to its base and rebuilt on a brand new platform that's going to allow us a lot more engagement. But as part of this new program, we're going to be recording your stories in small clips. So at 3 o'clock in the morning, when you're going to do a stress echo the next day and you really don't know what to expect, you're going to be able to come to the HCMA site. You're going to see a video of a bunch of patients just like you who've gone through the same thing, and you're going to hear directly from them what their experiences were. On the same page, there'll be a physician box and people that you recognize here who I will be calling out to say, hey, I need to videotape you for this, guys. They'll be there to tell you why they think these tests are important and what they're hoping to gain out of them and what you should expect. And then there'll be an HCMA perspective as to what our point of view is on why, whatever the topic might be, I don't know, but you'll get our point of view as well. So you get the patient, the doctor, and the advocacy group giving you some information, hopefully calming your nerves and making everything just a little bit more tolerable. We're also doing our Tales from the Heart podcast. Every other Friday, I'm interviewing physicians. Upcoming, I will be interviewing Robert Blum from Cytokinetics, and we'll talk a little bit about the business of developing medicines for people with HCM. Really interesting talk coming up. And we will also in the future be taking part of your stories that you're sharing with us and weaving them into podcasts on topics of interest to those with HCM. Surviving cardiac arrest, living with an ICD, post-myectomy, and we'll have discussions. So I'm looking forward to some more of that. This is the first time that this logo is being seen outside of the office. The Elizabeth T. McNamee Legislative Subcommittee started last October, actually almost a year to the day from today. It's a year and a week, I think. If you are interested to learn more about this, we're going to be having webinars on what exactly we're going to be doing. There will be more in depth, but we're looking to include cardiac evaluations and well-child examinations rather than waiting for a PPE, a pre-participation screening physical. We want every child and every family to have the opportunity to discuss their heart health history with a healthcare provider. It's an easy ask. It's a nonpartisan issue. We're going to be working on state level legislation first. Obviously, we want to make sure that all of our members and anybody with a pre-existing condition can maintain their health care, regardless of where the next couple of months take us. We need to advocate on behalf of making sure we have access to care. So if you would like to be involved with that, you'll be given volunteer opportunities soon, and you can sign up for these programs. If you have not yet watched our patient-focused drug development meeting, I encourage you to go to YouTube and watch it today. It was an amazing 4.5 hours where your voice was heard directly by the FDA. We are now creating our Voice of the Patient report, which will be presented to the FDA, and it will be part of their data set of information that they look at to review new drugs and to see what the patient really wants from a therapeutic and what we're willing to compromise for a new therapy that might help us in one way and allow us to be part of that shared decision making of when is it right for us. So if you go and you watch the video, you will see people like yourself. We have here we have goodness, we have Kelly, Priscilla, and Scott on the screen here who shared their story of HCM. When the new website built out a little bit further, you will see more stories like the ones here on the HCMA website that will branch off of the Share Your Story system. And with that said, I hope everybody wakes up now because I'm going to hand it back off to, I guess Roselle goes next. Yep, Roselle. I conclude, but I want to thank all of our partners at UCSF for their years of dedication to the HCM community, all of our Center of Excellence partners around the country and those ones out of the country as well. To my great staff, none of this would be possible if I didn't have a fantastic team here at the HCMA, our board of directors, all of our volunteers. And for those who don't know, I am a transplant recipient, and my transplant was only made possible because of a young lady named Brandy. So Brandy's with me all the time, so I like to just take a moment and recognize Brandy and remind you all to sign your donor cards, because even if you have HCM, you can still be an organ donor, and you might need to be a recipient someday. So please sign your organ donation cards. And that is all I have to say today. I'm going to stop sharing my screen. And oh, look, you're doing really good on that poll. I can see that now. And hopefully, let's take a break here for just 1 second. I'm going to say, everybody, while Roselle's getting her slides up, finish taking that poll if you haven't taken it yet, and we'll tell everybody who is here so our team at UCSF knows who they're talking to. You're talking to the world today. I can tell you that much. Okay, and I'm going to end the poll in 5 seconds. And here we go. So most of you are in California or the West Coast. Some of you are from the Midwest. Some of you are from the Northeast or Southeast and Southwest have taken Saturday off. Europe and Australia, New Zealand are with us as well. So we have reached worldwide status already. So, oh, share results. There they are. I thought I was sharing them while I was telling you that. So that's who we've got there. Most of you are patients. Some of you are a patient and a family member. Few of you have family members with HCM. Let's take a look at the diagnostic journey here. Some of you have been diagnosed within the past 2 years. That's a tough one, guys. Stay engaged. We'll get you through that first 2-year hump. Most of you are on meds. 50% of you have ICDs. 37% have had a septal myectomy or ablation. 41% have experienced AFib. 22% of us have lost a family member. 48% are genetically tested. And some of you are considering ICD or septal reduction therapy. So you have some decisions ahead of you. So we'll learn more about that today. Without further ado, I'm going to mute my mic. I'm sure you're happy about that. And I'm going to hand over to Roselle, who is going to come to you from the box. It says Catherine, but it's Roselle and Catherine at UCSF, and you need to unmute your microphone. There you go. All yours.
Good morning, everybody. Thank you, Lisa, for and the HCMA for organizing this wonderful conference, and for all the support you've provided to us and to the HCM patients through the years. And we look forward to continuing to collaborate with you and presenting not only some of our clinical work, but also some of the research we've been doing with a goal of precision medicine, which is basically trying to come up with individualized therapies for patients and their families. And so, as we all know, hypertrophic cardiomyopathy is the most common cardiac genetic disease and the most common cause of sudden cardiac death in young individuals. Importantly, there is a huge variation or variability, which we call heterogeneity, in what the heart looks like. And so this slide shows varying patterns of thickening or hypertrophy. And in this case, some patients can have almost normal looking hearts, and the location of the hypertrophy can be very variable. And this location of hypertrophy can influence symptoms. For example, patients with hypertrophy at the base of the septum are more likely to have a flow tract obstruction and need a myectomy or benefit from a septal ablation, while patients who have more of this mid-capillary obstruction also have obstruction, but they may not be candidates for a septal ablation, but they may be candidates for a myectomy. And there are others like apical HCM who may not have any obstruction at all. And so we have seen that even in the same family, patients, different individuals in the same family can have different cardiac phenotypes. And so when I mean cardiac phenotype, it is differences in the degree and the location and the pattern of cardiac hypertrophy. So another interesting, important point in hypertrophic cardiomyopathy is there is a heterogeneity in clinical phenotype, which means patients with hypertrophic cardiomyopathy can present with a variety of symptoms or no symptoms at all. Patients can be asymptomatic. They can have obstruction to flow of blood out of the heart, resulting in symptoms like shortness of breath, chest discomfort. Patients can be non-obstructive and can never have obstruction, or patients can have obstruction that gets relieved and then they become non-obstructive, or they can be non-obstructive throughout their lifetime. Patients can eventually develop heart failure. They can present with chest pain without obstruction or without any disease of their coronary arteries. And they can present with arrhythmias, which could be either atrial arrhythmias and or ventricular arrhythmias. And so the presentations of HCM patients can be very variable, as is the pattern of hypertrophy in the heart. And so today I will focus on two clinical hypertrophic cardiomyopathy phenotypes, and those are angina and arrhythmia, and I'll provide a little information on our HCM Research Program at UCSF. And so getting back to the basis, sarcomeric hypertrophic cardiomyopathy is caused by mutations in these proteins and that are important in contraction. And importantly, though, only 50 to 60% of patients have these mutations, with 40 to 50% of patients having no known mutation. Yet, they all present with a similar pattern. They all present with a similar pattern, which is a thickening. And so, despite the mutation or lack of mutation, most patients eventually end up with thickening of the heart, which can be progressive when they present to the center. So, given the marked variability in the cardiac appearance or thickening, as well as symptoms, we provide this very extensive evaluation to patients before seeing them in the first clinic visit. So we get a detailed history. We perform a stress echocardiogram. So we look at the perform a detailed echocardiogram at rest and following exercise. And what we're interested in is the location or presence of obstruction. Do these patients' heart rate go? Does the patient's heart rate go up with exercise or not? Because sometimes the patients may not have obstruction, but their heart rate may not go up, and that is why they may be presenting with shortness of breath. So the exercise test provides a lot of information in terms of trying to understand what is causing the patient's symptoms. So our goal of the program is to understand what is causing symptoms and then come up with therapies to prevent complications and to give patients a very high quality of life so they can do whatever it is they would like to do. And in order for us to be able to do that, we need to be able to understand what is causing any given patient's symptoms. And so this battery of testing enables us to figure out what is the patient's physiology, or what is the heart behavior, what is going on with the heart, and how that could be causing patient symptoms. And so we look at the response of the blood pressure to exercise. We look at how much the patient can exercise. And we do this yearly because we want to see if there's been a change in patients' exercise capacity. And patients often slow down, but they don't realize that there's actually been a change. And when we document it with the stress test, we're able to figure out what it is that's causing this change in functional capacity. We do a rhythm monitor, and if patients have an ICD interrogation, and the goal is, again, to see if patients are at risk for deadly arrhythmias like ventricular tachycardia fibrillation or atrial fibrillation, which increases risk of strokes in HCM. We do a cardiac MRI because that gives us a very good picture of the heart. It gives us an accurate measurement of left ventricular mass. It helps to diagnose apical HCM because the apex may not be very well seen on an echocardiogram. It helps us diagnose apical aneurysms, which are very important causes of ventricular tachycardia, and also strokes in the absence of AFib, as well as location of hypertrophy and fibrosis, because what we are interested in is not only, okay, so the patient has fibrosis or not, but we want to put all the information together to understand if the patient has significant myopathy. And what we mean by myopathy is the mutation or the genetic problem causing a marked dysfunction in the heart? Often we don't, looking at the echocardiogram and looking at an ejection fraction, we don't get that information. So we do more sensitive tests to be able to understand whether a patient has myopathy, because that, in our experience, correlates with outcomes. So we do refer all our patients to genetics for genotyping, because we think this is important for family members, and we explain to patients that it's a gift you can give to your family if we do find that we find a mutation, so we can screen family members. And the most important is risk stratification for sudden cardiac death and atrial fibrillation. We also have, the way our program is structured is we see the patient initially, we see how they're doing, and if they have symptoms, we follow them up closely until we get to a point that the patients are doing well, and then we follow them once a year and have them follow up with their hometown cardiologist. And once patients are stable and doing well, we follow them yearly, and we again get a detailed history. We do a yearly exercise echocardiograms. We do yearly rhythm monitors and ICD interrogations. And every year we reassess the risk for sudden cardiac death and atrial fibrillation. And the reason is that since we don't yet have a way of preventing disease progression, we need to assess at any given point in time what a patient's risk is, because that risk can change over time as the heart changes. And so this is a team effort. Kate and I and Ted and Julianne, we work very hard to understand what the patient's physiology is, and then figure out what to do next. And again, our goal is to improve patients' quality of life and prevent complications rather than deal with complications once they happen. So coming back to angina, importantly, we usually think of angina as chest pain, which is caused by blockages of coronary arteries. But importantly, in hypertrophic cardiomyopathy, we see angina even in young individuals. And when we do a coronary angiogram, we find that they have no blockages. And so I tell my patients that I try to explain it to them that hypertrophic cardiomyopathy, if you think of a house, hypertrophic cardiomyopathy results in a change in architecture, but doesn't necessarily cause a change in plumbing. And so we do a coronary angiogram to assess the plumbing, and the plumbing is usually good. And that the hypertrophic cardiomyopathy can cause a change in the electrical system. And then we assess the architecture, the electrical, and the plumbing in every patient. And so importantly, the coronary angiograms are usually normal in younger patients, but they still can have significant chest pain. And so what is causing this chest pain? So pathology studies in hypertrophic cardiomyopathy have shown that the arterioles, the smaller arteries that supply the heart muscle, you can see that they are thickened. And so instead of being wide open pipes, there's a lot of cells that keep dividing and narrow this artery, which then causes chest pain and can also contribute to developing a scar. And so essentially, patients have normal coronary arteries, which is the big artery supplying the heart. But the smaller branches that supply the heart muscle itself can be narrowed, not because there's cholesterol or plaque in them, but because there's the same hypertrophy. So just as you have thickening of the heart muscle, here there's thickening of the muscle lining the arteries, and that contributes to angina. And so in these patients, so when patients present with angina, the first step is to rule out obstruction. So if patients have angina in the absence of obstruction, then it could be from microvascular dysfunction, which is that the small arteries supplying the heart don't work very well. And it's important because these patients can have angina, which can be debilitating. It could contribute to arrhythmia as well as heart failure. So what we do is, an important test to diagnose microvascular dysfunction is an ammonia PET scan. And so this is just an example of a patient where essentially these donuts are the myocardium that is cut in a cross section, and what we see is this bright color, and then you see this sort of darker color. So at rest, which is these images, the blood flow is good, but when we inject a stressor, the blood flow is low in the heart, and the blood flow can be so low that it actually resembles coronary blockages. But these patients do not have coronary blockages. It is just these small arteries in the heart that have the hypertrophy of the smooth muscle, which then contributes to flow problems and angina. So we think, and others have also shown, that this regional myocardial ischemia can cause electrophysiologic changes that can then contribute to arrhythmias. And this is an example of what an arrhythmia looks like. This is a computer simulation of a ventricular fibrillation. And essentially what ventricular fibrillation would look like is that there are a lot of wave fronts that are moving around the heart in a very chaotic fashion. And as a result, the heart is unable to contract in a synchronous way, but it just contracts in an abnormal way, which then results in death. So we think that microvascular dysfunction could contribute to arrhythmias and hypertrophic cardiomyopathy. The next topic is arrhythmias, which are very common in hypertrophic cardiomyopathy. So patients with hypertrophic cardiomyopathy can have both ventricular and atrial arrhythmias. As I said before, and as you all know, HCM is the most common cause of sudden cardiac death in young individuals and athletes, but older patients can also have arrhythmias. Sudden cardiac death often occurs either during or following insertion. And importantly, ventricular tachycardia fibrillation, which can be life-threatening, could be the first presentation of hypertrophic cardiomyopathy. Importantly, the risk of ventricular arrhythmia decreases with age, except in patients with apical aneurysms, which often result from patients with mid-capillary obstruction. And those patients are often older, and they are also at risk for ventricular tachycardia and fibrillation. Another important arrhythmia is atrial fibrillation. The prevalence is 20 to 25% in the HCM population. And it's important because patients can be short of breath, they can have palpitations, but most importantly, they can have stroke can be the first presentation of atrial fibrillation. And we do know that giving anticoagulation can prevent stroke. And so we believe it's very important to be risk stratifying not only for sudden cardiac death, but also for stroke, for atrial fibrillation and stroke. And this is just a little bit of some information on what causes arrhythmias. And so we do know that patients with HCM have thickening of the heart. The myocytes are not in parallel bundles, but they can be in different directions. There is scar, which we can diagnose by MRI. And there's changes in the electrical properties of the myocytes, which contributes to an abnormality in substrate. And so the more the degree of disease, or the more the hypertrophic cardiomyopathy mutation affects the cardiac myocyte and the heart, there can be more abnormalities of the substrate. But substrate alone is not sufficient to cause an arrhythmia, because the substrate is something that's there all the time. On top of the substrate, there's triggers, and the triggers can be microvascular ischemia, abnormalities in calcium, which could be specific to mutations, as well as energetic deficits or metabolic problems. And that is one of the research focuses of ours, as well as oxidative stress. And so these two can be dynamic and can be the trigger for arrhythmias. And essentially, the arrhythmias are ventricular tachycardia, fibrillation, AFib, and all of them are reentrant arrhythmias. Essentially, it means that there is a scar, there is a trigger, and then you have these waves that keep re-entering. And those cause atrial fibrillation and ventricular tachycardia and fibrillation. So our goal of one of the goals of our program is to improve arrhythmia and risk stratification using a combination of multimodality imaging, blood biomarkers, and machine learning. And eventually is tailored therapies to prevent arrhythmias rather than treat them. Because once patients have an abnormal substrate, it's difficult to reverse it, but our goal would be to prevent development of the abnormal substrate and thus prevent arrhythmias. So just a little bit of a few pictures on what fibrosis looks like, or scar. And so the mutations that cause hypertrophic cardiomyopathy cause scar, and that scar could be depth of large numbers of myocytes, which cause what we call replacement fibrosis, which can be seen on an MRI. It's called late gadolinium enhancement. And another one is thin fiber-like fibrosis called interstitial fibrosis, which you can also quantify by MRI. And so MRI is really helpful in identifying or characterizing the rhythmic substrate in hypertrophic cardiomyopathy. But in our clinical practice, we use guidelines. And so there's two sets of guidelines. One is from the ACC/AHA and one is from the ESC. And we use these to identify patients. We use a combination. We use both the ACC and the ESC guidelines to identify patients who are high risk for ventricular arrhythmias, to help them decide whether they would be interested in getting a defibrillator. There's two kinds of defibrillators, a transvenous and a subcutaneous. And the decision of transvenous versus subcutaneous is based on a patient's exercise test. If patients have problems with increasing their heart rate with exercise, we usually recommend a transvenous, because with the medications that we give them, like beta blockers for obstruction, it can reduce their heart rates, and having a transvenous ICD allows us to pace them. Similarly, presence of any heart blocks during rhythm monitoring tells us that these patients would benefit from the pacemaker function of a defibrillator. And so these patients we recommend transvenous ICDs, and younger patients who don't have conduction system problems or pacemaker problems, we recommend a subcutaneous ICD. So this is a little bit about atrial fibrillation. So we have now started doing MRIs to assess the amount of scar in the ventricle. So it is very well established that MRI can look at scar in the ventricle, but not in the atrium. And these are images of the atrium, and the blue is normal myocardium and red is scar. So this is an example of a normal control. That is a healthy individual, has very little scar. And these are hypertrophic cardiomyopathy patients, all these three. So this first patient has scar, you can see, but does not have AFib yet. This patient has scar and has AFib, paroxysmal AFib. And this patient also has paroxysmal AFib, but has a lot of scar. And so we believe that including this imaging of the left atrium could help us identify which of our patients would develop AFib and be very vigilant about atrial fibrillation diagnosis and the initiation of anticoagulation, because we believe that this scar just reflects myopathy in the left atrium. And so in addition to the scar, we also measured mechanics in the left atrium. And we believe that a combination of imaging of left atrium as well as a machine learning model will help us predict which HCM patients are at risk for atrial fibrillation. But more importantly, we believe that this data will help us understand what the pathophysiology is of atrial fibrillation in humans. Most of the studies in hypertrophic cardiomyopathy are done in mice, but there is a huge difference between mice and humans. Mice do not develop atrial fibrillation while humans do. And so we believe that it is very important for us to do studies in humans in order to understand what the pathophysiology or what are the drivers of disease in humans, so then we can then come up with therapies that can prevent scarring, abnormalities in cardiac mechanics, and eventually atrial fibrillation in the future. And so in collaboration with computer scientists, we are developing models, machine learning models that enable us to add data as it gets available. And our goal, again, is to predict atrial fibrillation in HCM. And to summarize our clinical program, we use multimodality imaging, and the plan is in the future to use machine learning to provide insights into HCM pathophysiology. The deep phenotyping, or this extensive battery of tests, permits us to tailor therapies to the clinical phenotype and give patients a high quality of life and prevent complications. Our clinical studies also help us get insights into the pathophysiology, and our goal is to prevent the development of complications as well as progression of the hypertrophic cardiomyopathy phenotype. Do I have some time for the, Lisa, do I have time for a few slides for the research, or am I over?
Of course.
All right, just a little bit about our research program. And so again, as I mentioned before, we have a lot of studies that are done in mouse models, which tell us about HCM pathophysiology. But again, very little is known about the molecular mechanisms underlying disease onset and progression in humans. And that is important because mice have a lifespan of a couple years, while humans have a lifespan of 80 years. And so there's other differences in physiology between mice and humans. And so while mice are great models, we also need parallel studies in humans in order to understand exactly what is driving disease in humans. And so in order to do that, we have, in addition to a comprehensive clinical program, we also have a comprehensive research program. And our comprehensive research program, we use clinical data that we get from, that we use to manage patients, and we call that clinical phenotyping, which is the natural history, all the multimodality imaging, the EKG data, machine learning. We also have model systems, which are cells, which are human cardiac myocytes, which are used by differentiating what we call programmed stem cells. We have animal models, which are mouse models, and we also have computational models, which are made using human data. In addition to that, we then have what we call integrated pathway analysis, which is big data, which is transomics. So we have metabolomics data, which is what's going on with metabolism. We have proteomics data, because what is going on with proteins in the heart, because they give us an idea of what the heart, what the cardiac myocyte is doing in response to what. We also have genomic data, which tells us what is regulating the changes that are going on. And so our goal is to combine all this data, eventually to develop personalized diagnostic tests and therapies for patients in their families. Not only in people with known mutations, but also in families where there are no known mutations, because we can develop cells from anyone. So we take skin cells or blood cells, and we can program them into cardiac myocytes, and then we can study disease mechanisms irrespective of what the mutation is. And we believe this is important because in hypertrophic cardiomyopathy, having a mutation doesn't mean you're going to get the disease, because there is this variable penetrance. And so what we want to do in humans is to figure out whether a person has a mutation or not. In families where there are mutations, and we have family members who have mutations, but they are completely asymptomatic, are they always going to be asymptomatic, or will they develop disease at some point? In those patients, in those individuals, it would be useful to give them therapies that would prevent development of disease, if we know that they would develop disease in the future. In families where there are no known mutations, right now, there's no way for us to know who is at risk of developing disease and not. And so our goal is to come up with diagnostic tests that incorporate genetic data, but do not necessarily need the genetic data, in order to identify who's at risk of developing the disease and also complications of the disease. So just a little bit about cardiac imaging. So cardiac imaging is very useful because it helps us look at what's going on at the heart in a non-invasive fashion. So we use echocardiography, we use PET, and at UCSF we have a PET MRI, where we can look at both flow and function at the same time. We use EKG, machine, just the regular cardiologist interpretation, as well as machine learning, MRI, and we also have this wonderful opportunity to do metabolic imaging using this this technology that was pioneered at UCSF, where we can look at metabolism in a human over a minute or so. So, and those are the clinical tools we have. And on the basic science side, we do studies in mice models. We do studies in cardiac myocytes, and these are examples of human cardiac myocytes, which were obtained by differentiating skin cells into stem cells into heart cells, and these are mitochondria. So mitochondria are the powerhouse of the cell. And so I tell my patients often hypertrophic cardiomyopathy patients have an energetic problem, and I explain it this way. So the currency in the U.S. is the dollar. If you have no dollars, you're poor, and the mint makes the dollars. Similarly, in the heart, in the hypertrophic cardiomyopathy heart, ATP is the energy currency, and they have a deficiency of ATP. And the mint that makes ATP is the mitochondria. And so what we need to figure out is how can we make more energy so that we don't have this imbalance between energy demand and supply. That's where we are here. So an important hypothesis regarding what causes thickening and scarring is this energetic imbalance hypothesis. And so the mutation makes the myocyte inefficient, and so it consumes more energy than is available. And especially, this is more prominent in states like high intensity exercise, where your heart has to generate a ton of energy in order to supply blood to your whole body. And so we believe that could be one of the reasons why people have arrhythmias during exercise. So, and we also believe that the energetic deficits could contribute to the hypertrophy as well as cell death and scarring. And so we have this whole program that goes all the way from the mitochondria to the cellular level to the human and the mice and cells in order to understand what is going on with the metabolism in hypertrophic cardiomyopathy. And so we've adopted this what we call a co-clinical trial model, which is used in oncology to understand what is going on in a particular tumor for precision medicine in oncology. But we are using the same strategy we plan to use the same strategy in hypertrophic cardiomyopathy, where we do parallel studies in mice and cells which are derived from patients, and our goal is to define pathophysiology, discover and test therapies, and discover biomarkers that can help us understand what the pathophysiology is in any individual patient and their family. Just a few slides on what we have, some interesting data that we have. So the one question we asked is, we know that gene expression sort of gives us an idea as to why a heart cell behaves in a certain way. And so the first question we asked is that how similar is gene expression in humans and mice? Because very often we use mouse data to predict what to do in humans. And so the only human data we could get is from myectomy samples, and that is patients who go for surgery, who have a piece of their heart excised to relieve the outflow tract obstruction. And so what we did was we compared gene expression in 2 mouse models. And this myosin heavy chain mutation results in in a human, results in heart failure in middle-aged humans. And this TNG mutation results in arrhythmias at a young age. And so these 2 phenotypes span the spectrum of human HCM, and they are based on human mutations. And we looked at RNA and miRNA, which are the small RNAs, and we did some pathway analyses. And interestingly, this is a very busy slide, but what I want to point out is that we found huge differences in signaling pathways in both mouse models as well as in the human. So there were huge differences not only in the mice, but between mice and human. There's very little in common between the mouse and the human. And we can use this bioinformatics program to predict therapies, and the therapies predicted were very different. Again, this is just 2 mouse models and myectomy patients. These are not patients with non-obstructive HCM. These are patients with severe obstruction who go for surgery. So we don't believe that they represent all hypertrophic cardiomyopathy. But this data from these myectomy samples has been used because that's the only tissue we have to be able to understand what's going on in hypertrophic cardiomyopathy in humans. And so every model we know has its limitations, and what we found essentially were huge differences. We then looked at gene expression in the same 2 mouse models at a very early stage, and again we found huge differences in gene expression, but also in redox. That means in the response to antioxidant therapy. We also saw differences in the mitochondrial function, in fibrosis signaling, huge differences in these 2 mouse models at early disease stage, suggesting that at the early disease stage, we may need to have more understanding of what the pathophysiology is in humans in order to find targeted therapy. So to summarize, we have found mutation-specific differences in mouse models at early and established disease stages, as well as in mouse and human at established disease stage. Interestingly, we found compensatory hypertrophic, anti-hypertrophic, and anti-fibrotic signaling in the myectomy sample. So these are patients with marked thickening and a lot of scar. But what we found was anti-hypertrophic and anti-fibrotic signaling, which is probably compensatory. And we believe that precision medicine approaches would be helpful in treatment of patients and their families based on the patient's molecular cardiac phenotype. Thank you for your attention. And this is a research study we are doing to look at cardiac metabolism in people. And we believe that it may be helpful for us in the future to figure out what is there one, are there several different metabolic phenotypes? Could we use this to understand who would be at risk for developing hypertrophic cardiomyopathy? We could perhaps use this to distinguish hypertrophic cardiomyopathy from athlete heart, because we do know that athlete hearts have highly efficient hearts versus hypertrophic cardiomyopathy has inefficient heart. And so currently all we use is looking at what the heart looks like and looking at strain, but if we could actually look at metabolism, we may be able to figure out who has athlete's heart, who has hypertrophic cardiomyopathy, who would be developing hypertrophic cardiomyopathy. And so this is just, we finished a small study of volunteers, and now we are open for recruiting hypertrophic cardiomyopathy patients for our metabolic study. Thank you very much for your attention.
Thank you, Rizal. I think we got our money's worth on that talk. We covered an awful lot of territory there. So I do want to just ask you a little follow-up question, and
Yes.
then just an editorial note to the viewing public here. Now you know why when this woman 20 years ago comes into my booth and starts going, I have all these ideas about hypertrophic cardiomyopathy, and she went poof, and I'm like, yeah, we need her on the team. So her excitement hasn't waned over the years, and her focus hasn't either. So we're talking about, some of this is kind of almost, bench science versus clinical practice. What do you think is a trajectory of timeline to take something like you're doing in the mouse models and trying to understand how they're metabolizing? How long do you think that actually takes to get to understanding what it does in a human? That's a long pathway, isn't it?
Yeah, but I think I think of it as stepwise. So in terms of clinical imaging, I think we are almost there. So I think using multimodality imaging to understand what's going on, using biomarkers, for example, we have the technology. We just need to have the right group of people working together to figure it out. And of course, there's a ton of work being done by other groups who are looking at biophysics and looking at all these contractile abnormalities, the super relaxed state, and this wonderful work going on, in terms of cardiac mechanics and the basis of it. So I think we have several different groups focusing on different aspects. And I believe that, putting it all together from the imaging standpoint, I think in 5 years, we should be able to get very good data in terms of what is going on in terms of metabolism, in terms of yeah, in terms of metabolism as well as more detailed functional data and biomarkers. What's going on with the mitochondria? I think that's very important. And if we can understand more about the mitochondria without doing biopsies, that's the goal. And I think we could get there in 5 years as to what is going on. Once we define what is going on, then we can define the targets that need to be addressed. And so I think it is not going to be one drug itself. I think it's going to be a combination of agents. And I would actually like to say a supplement and maybe something else that could help. And so something that doesn't have much toxicity, but could help change the regulation of gene expression, redox state. So I'm hoping that the imaging would be 5 years, but then after that, we could then identify targets, so maybe 10 years for some targets to get some therapies. And again, I think it's even the current therapies, they're not, bad, they're good. I mean, we have ARBs, which are predicted in our bioinformatics for one of the mouse models. And so I think the question is which therapies to deploy in which individuals, and also more importantly, what would be useful to prevent disease, to prevent the development of the substrate.
So it's a why and a when.
Exactly. So,
Yeah.
So we have to figure out why, and then I don't think it should be difficult to figure out how to address it. But I think we need more.
I'm glad you don't think it's difficult, but I don't think you.
5 to 10 years. I think 5 to 10 years, especially in the Bay Area. There's so much technology and infrastructure and everything. So I think we are primed to deliver.
I hear you. Okay, we're going to pivot now, and we're going to have you unshare your. Actually, you can share your screen because Catherine's going to be speaking next. We're just going to change the presentation, and Catherine's going to talk to us a little bit about what to expect from the UCSF experience with their HCM program. I was out there, it wasn't that long ago, like within the past 2 years, we were out there. I was hoping to be out there again this year to launch some of these programs there, but tell us what's going on. Tell us how patients get engaged. And I leave the microphone to you, my dear.
Excellent, thank you. Thank you for all of our patients, our colleagues, and everyone that's joining us today. And of course, to the HCMA and Lisa for bringing us all together. I'm excited to tell you about our HCM 360-degree HCM evaluation here at UCSF. Our mission, as Roselle said, I think it's one that we strive for every day. Our mission is that we are here to serve you and your family with the goals of symptom management and prevention of complications, so you can live a life that you want to live. We hear your stories all the time about wanting to get back to dancing or hiking or whatever, chase around those grandkids. So that's what keeps us focused. And really, as everyone has touched upon, it takes a whole team. It takes our evidence-based practice, it takes cutting-edge research, and it takes our top testing modalities, along with listening to your story. And so if you've been to UCSF before, you've probably seen some of these friendly faces. And we might be the people featured here today, but really, as everyone said, it takes a whole team. And so here at UCSF, we're really a great one-stop shop. We have electrophysiology, we have cardiac rehab, which is huge for HCM. We just opened a new cardiac rehab program, and they are pioneering virtual cardiac rehab. What does that look like right now during a pandemic? We have social workers, financial assistants. We know that we need to take care of you and all the worries that you have. So what we start with is getting to know you. As Lisa mentioned, usually there's a little bit of fumbling in the beginning. Usually, it's a case of a young person or somebody who's otherwise healthy and they're presenting with symptoms that maybe don't make sense. And so we really dig deep into hearing your story, what you've already been through, what you feel in your body, what limitations you might have that you're trying to improve, what testing have you already had, what medications have you already tried. We talk about your medical history because we know there's other issues like diabetes, thyroid disorders, anemias that also need to be addressed in order to have the best outcomes for your HCM. And of course, we always put in, what are your goals? Like I said, what are your goals? What is it that you want to be able to do? And by the end of this targeted history, it's also based on our research of what are important questions to ask, like history of a heart murmur, your exercise history, even history, gestational history for women. What was it like when you were pregnant? Were you holding more fluid, you think? Those little subtle things that maybe aren't always asked. We care about those details. And then by the end of this phone call, it's usually with me, we can decide on the plan, what testing needs to be done before you meet with one of our wonderful physicians. So that visit to our clinic can be as productive as possible. So testing, I'm going to talk about it in very basic terms. What we're looking at here, and Roselle mentioned this very common sort of metaphor that we use, where we compare your heart to a house. And what we're really doing is we want to do a deep investigation of your heart or your house, right? You wouldn't just look at the walls of a house. You also want to make sure that the lights can turn on, right? The electricity works and the door can open and close. And what this, in cardiology, we call all of this testing phenotyping, or what is the physical expression of HCM in you, the individual. So to bring this metaphor home, if you look at your house, in this house here, you have 4 rooms. So just like that in the heart, you have 4 chambers. You have your top 2 atria, your bottom 2 ventricles. In your home, you also have doors that should open and close with no problem, just like the valves of your heart, of which you have 4 valves. In your house, you also have electricity that you can turn on and off. And in the heart, we have electricity that is hopefully always going, nice and normal flow of electricity. And then last but not least, we have plumbing in the heart. And the plumbing in the heart, I pictured over here, it's the arteries that supply oxygenated blood to your heart, and they sit on the outside of the heart. So we're looking, again, a 360-degree evaluation. And here at UCSF, we do all of these tests, but we do it with special protocols. So we have echocardiogram, of course, and we have echocardiogram, of course, and we also have stress echocardiogram. Of course, this is what's going to help us to look at the walls, right? We know the hallmark of HCM is heart wall thickness or hypertrophy, but as everybody has touched on today, these tests help us look at so much more, because we know it's not just about the left ventricle, but we have to look at those valves or the doors of the heart. We have to look at the top part of the heart or the atria, those top floors of the house. We have to take a 360-degree approach. With exercise, as Roselle mentioned, we also get more detail into, your symptoms. What's going on here? Is your heart rate going up? Are you having abnormal heart rhythms? What's your blood pressure like when you're on that treadmill? And then we also use MRI to look at the heart muscle as well and get that characterized. One good point about the difference between echo and MRI is you can kind of see here where white is muscle, black is blood. We don't really get to the very bottom of that picture, or we do not see the apex of the heart or the very bottom of the heart. But then here in the MRI below, you can see we can very clearly define that apex or the bottom part of the heart. Another important part of echo is that we can characterize these, not only look for scarring, which is very important, as Roselle touched upon, regarding your risk for cardiac arrest and other prognostic indicators, but we can also get more details if you have something like an aneurysm here featured in that MRI. And then checking the electrical, we use multiple modalities, not just your resting EKG, but we do long rhythm monitoring. We do a 2-week rhythm monitor. And this is because we know that not all, you may feel fine, but you also may have abnormal heart rhythms. As we've all alluded to, you can have no symptoms, but these things can still be going on. Lab work is also an important part. Our initial lab work that we have all of our new patients complete is very detailed. We're looking for not just HCM disease markers, like looking at your pro-NT-BNP as a marker of possible heart failure, or troponin, looking at cell death, but we also look for information about phenocopies. meaning what I like to call our copycats, right? These other diseases that can mimic HCM. So things like amyloidosis, Fabry disease. And our lab work helps hopefully rule some of these out or screen for them. So we're not fooled and we make sure that we get the diagnosis right. We also have obviously a wonderful comprehensive genetic counseling and genetic testing. I'm going to leave that very brief because Julianne will be talking about that in more detail. And you know, Ted always says we kind of have like 2 levels of testing. You always have to go through your first level. And then, you know, if we need more information, we're very lucky here at UCSF that we have advanced testing. So testing that's not going to be available at your community cardiologist, like the ammonia PET scan that she talked about that can help us screen for microvascular disease. Microvascular disease can cause debilitating angina, and we have medications to help with that. We also offer exercise. We also look at your exercise tolerance measured in a scientific way with what we call cardiopulmonary exercise test, also known as VO2 testing. So while we use this in our Olympic athletes to help them train to the best of their ability, we also use it in cardiomyopathies, not just HCM, but other heart conditions to see really, are you limited by your heart? But we can also see if you're limited by your lungs, or if there's something else that's limiting your physical capacity. Lastly, one of the advanced testings that we offer is cardiac catheterization. This allows us to, you know, sometimes when there's a mismatch in how the patient feels and what we see on other imaging, we rely on direct measurement. And this is through a cardiac catheterization procedure. And so during the procedure, we can measure the pressure in each of the chambers. We can even look into the lungs, because in some cases we know that you can also develop pulmonary hypertension as a complication to hypertrophic cardiomyopathy. So that's really important. We also have the ability to do direct pressure measurement, meaning we can take this catheter into the left ventricle and directly measure that gradient, not just from the ultrasound or the echocardiogram, but directly. And then in rare cases, we can also consider doing a cardiac biopsy. Again, looking for mimickers or copycats of HCM, like amyloidosis. And then we meet together and we put it all together. We ask you to bring a family member or a friend, even during this time of COVID, if you want to have somebody on the phone with you, bring a list of your questions and your concerns. We provide you with detailed patient education and work on your treatment plan together. So that first visit, there's a lot to go through. But myself, our care coordinator, Hazel, and the rest of really the family here at UCSF, we're here to walk you through that. So by the time you meet with either Dr. Abraham, you have an idea of what to expect, but also we have the information we need so you can leave your clinic visit with a plan. And remember, we're here to serve you. So if that first plan doesn't work, we try again. We don't give up. We don't just scratch the surface. We do not leave any stone unturned. And so my presentation was very brief, and I hope informative and helpful though.
I think it was very informative, and I think you gave a very good overview of what patients can expect and how to best communicate with the program. I do have a couple questions I'm going to pose as we go forward so that I don't lose them. This is kind of, if Roselle's still there, Ted, if you want to unmute as well. To what extent or how frequently do you believe poor lifestyle or other pre-existing medical conditions can cause asymptomatic patients with HCM to become more serious, increased scarring, hypertrophy, AFib, VFib? So I'm going to rephrase the question because I think it's a complicated question, Doug. Are there factors, lifestyle factors for patients that they should consider because they may contribute to aggravating hypertrophic cardiomyopathy?
Absolutely. That was a great question, Lisa. So we usually tell the patients that this is a genetic disease, but there are environmental modifiers. And we explain to them that the environmental modifiers are sleep apnea. So we always obtain a history of sleep apnea, and we get sleep studies in patients. Now we have the ability to get home sleep study. So that's very convenient. So patients pick up the home sleep study and they get their home sleep study done, and they follow up with the sleep clinic. And if there's need for an in-center study, they'll do it. So the environmental modifiers are sleep apnea, obstructive sleep apnea. Patients with hypertension that's not well controlled can contribute to worsening of the hypertrophy. Scarring. We tell patients that intense exercise, heavy weight lifting, intense exercise could contribute to worsening or more rapid progression of the cardiac phenotype or onset of the disease in patients who would otherwise be asymptomatic. And we also tell them that obesity we would like them to embark on a exercise program, and we put them in touch with a dietitian, and we provide detailed advice on exercise, low to moderate intensity exercise. And so if despite everything, if the patient's phenotype doesn't appear to be significant, but they still have a lot of limitations, then we get the VO2 treadmill, because we want to know, why are they limited? Is it because of deconditioning that they can't really do much, or is it truly a cardiac limitation? And then on the other hand, if you have patients with a very significant cardiac phenotype, those are the patients that we are very vigilant about complications, because we know what complications are associated, like with the main complications: heart failure, ventricular arrhythmia, sudden cardiac death, and stroke. And so we want to make sure that these patients with a lot of abnormalities on their imaging, on the MRI, if they don't fulfill criteria, we want to know how we're going to monitor them really closely. We may have to put an ILR, an implantable monitor in them. So we tailor our testing also to the phenotype. And so if somebody's phenotype is mild, we push them from a lifestyle standpoint, but the phenotype is severe, then we really want to look for complications while sort of helping them do the best they can with their underlying phenotype. And we think exercise is an important, we tell patients drinking a lot of water and exercise are like two free things that are free and don't have any side effects. And then we recommend it because we do think that exercise improves energy efficiency and improves ATP energetics in the heart. And so that's one of the things we're also going to look into with our research program.
One other question, and then we'll go to the next talk, and that is, do you think CoQ10 supplements could help HCM patients? It is this questioner's understanding that it helps with ATP. Would you comment on CoQ10?
So we don't know. So coenzyme Q is a part of the electron transport chain. So if we did, and there are patients with known mutations of this particular element of the electron transport chain who present with thickening of the heart that looks like hypertrophic cardiomyopathy, and they are the ones who definitely need CoQ10. And I have taken care of these patients. But right now, I don't have any evidence that CoQ10 would be harmful or beneficial, because I haven't really looked at that in humans. And so we do see electron transport chain abnormalities in mice at a later disease stage. And so I can't think of a downside to it right now, but I don't know that it's truly beneficial because we haven't really looked at. What would be good is to give the supplement and then look at an effect on a particular, figure out what the target is and what imaging or what test we could do to evaluate the beneficial effect of it. And we also have to pick the right people, because if it is somebody who's just doing well, whose phenotype is mild and they continue to be mild, they would have been mild irrespective of coenzyme Q10, but then there are others who may benefit from it. So I think it needs to be done in a more planned fashion to evaluate the benefit of coenzyme Q10, but I don't see any downside to taking it. So
no downside, but maybe no upside specific to HCM. Okay, I'm gonna have you guys
Lisa,
got
I wanted
Oh, did you want to bring up? Okay.
Yeah, I wanted to bring up one other fascinating service we have here at the UCSF, which is our collaboration with the Human Performance Center at UCSF. So it's not directly part of the hospitals, but it's part of more of the research that goes on. But available, we do have exercise physiologists, and we have connections with them, and you can meet with them, and they will actually watch you exercise and help provide you with a personalized exercise plan. While we provide you with very, our as detailed information as possible, if you're somebody who's an active exerciser or an avid exerciser, you may be interested in getting a more detailed exercise plan from that physiologist.
That is a phenomenal service. So thank you for providing it. And we were actually discussing in a previous tour that, or maybe it was in another meeting I had this week. I had a busy week. That it would be really great if all patients with HCM could have, at least 1 or 2 sessions in cardiac rehab being monitored to know where their limits are and to help them feel comfortable exercising.
Exactly.
So
exactly.
it is exactly what I want for everybody with HCM, like all the time. So see if you can't plant that elsewhere in the country. Next up to bat is Julianne, who's going to talk to us about genetics. And it is a complicated topic, which she is going to actually make quite simple and understandable for genetics. And you have one of my favorite pictures in your slides. I've always liked that first one that you're going to use. And off to you, Julianne. Thank you.
Thank you so much, Lisa, and thanks to the HCMA community for the opportunity to chat with you all today. It's been just really, really fun to hear the talk so far. So I am a genetic counselor in the program, and my talk is on the new developments in HCM genetics. And so to do this, I'm going to figure out why my slide is not advancing. There we go. Sorry about that. So just to kind of give you an overview of my talk today is I'll spend a little time talking about kind of the classic understanding of HCM genetics and how our advances in technology, both in genetic sequencing and analysis, data collection, and testing strategies have really impacted and put into question some of these classic beliefs that we've had. And then ultimately how this impacts patients and families in order to provide them more tailored, individualized care. As with any new knowledge and developments, sometimes it brings forth more unanswered questions than answered. So just as a review, of people have touched on this before, HCM is clearly a genetic disease. Our knowledge of HCM really stemmed from a time when we really were limited in our ability to actually sequence DNA. And so we got our information mainly from the observation of families with HCM. And so in order to observe a trait, you have to be able to see it, right? You have to be able to see that there's multiple people in a family who all have a given condition. And so that inherently brings forth bias in that the first families that came to our observation were those who had very severe disease in many, many generations. And so that led us to conclude that this is a dominantly inherited condition due to a single gene mutation that's passed on in a 50-50 pattern. So anybody with the mutation has a 50% chance to pass it on to each of their children. Those who test positive will have a high risk of developing disease, while there might be differences in the age of onset and the severity of the disease. If you have that mutation, you would develop disease. Now, in our kind of classic understanding, we find a mutation in about half of the families that have quote unquote HCM. And this understanding of HCM genetics has really informed the testing strategies as well as the family screening strategies to date. And just to mention on genetic information. So again, going back, our classic understanding of HCM genetics was basically from finding these handful of sarcomere genes that we know are associated with HCM, proofreading them and finding a change in a family and determining that that is the underlying genetic cause of their condition. Now, there are lots of different ways to change DNA. What you can see here, this wild type is a fancy name for normal, and this is the DNA sequence, which is a number of, with basically abbreviated as letters, and there are only 4 of them, so there's 4 letters in your genetic code. Each combination of 3 equals 1 amino acid. Putting those all together equals a protein. So you can have mutations or variation rather, that's very subtle. It's just changing a single letter, an A to a C, but doesn't change the amino acid. The vast majority of the time, these are normal. Then there's a little more significant where there's, again, a single letter change, but it changes a single amino acid. This is something that's termed a missense mutation. This can be very subtle, benign, cause no problems, or it can actually be disease causing. And then there's a couple of types of mutation that are a bit more severe. One is called a nonsense mutation, and that's basically where instead there's a single change, but that puts a premature period at the end of the sentence. So basically stops the protein from being made prematurely. These very frequently cause disease, though not invariably. And then frame shift mutations. This is kind of similar. You have a single change, but instead it's either an insertion or a deletion, causing everything afterward to be abnormal. Again, these are more severe and tend to cause disease, but not always. So in order to look at all of these different changes and try to answer the question of, did one of these cause or is one of these responsible for someone's HCM, we have to classify it. And there's an accepted framework for classification of genetic variation that falls into these categories. The first 2, pathogenic or likely pathogenic, you can substitute disease causing for that. These are considered positive. These are considered, this is the cause of your condition. We know other family members are at 50-50 risk and should be screened. The ones on the bottom are essentially normal variation. This does not cause HCM. And then there's a giant middle range where we don't have enough data to be able to put them in either of these 2 categories. And it's a big question mark. And you'll see this a lot with genetic testing. And the more genes that are analyzed, the more variants of unknown significance that we find. So talking a little bit about advancements that over the course of the last decade or so is mainly with regard to sequence technology. We have new sequencing technology that's much faster, much less expensive, provides a great deal of data that is increasingly shared, thankfully. Historically in genetics, people were very, they didn't want to share their data because they thought it had value, but now we're doing that much more as a community, which helps with analysis. This has led to increased awareness. It is also with regard to increased advancement in knowledge of HCM and increased awareness of the condition. So more cardiologists are aware of the condition, diagnosing it more readily. Increased availability of genetic testing. As the cost of genetic testing has gone down and more laboratories are offering it, we actually can then see that more individuals are getting access to this service. It's also, we've recognized that we have much more genetic diversity than we ever thought possible. And this is again leading to increased likelihood of getting a variant of unknown significance in a genetic test result. One other thing we're learning is that a genetic mutation or disease-causing variant is not necessarily a deterministic factor. It doesn't necessarily guarantee someone will get disease. It increases the risk, and probably different variants increase the risk differently, such that you're actually probably, in many cases, instead of the clear-cut absolute viewpoint we used to have, looking at a risk continuum where a given variant might confer some degree of risk. And as Roselle had said earlier, some of these other non-genetic risks could influence that risk continuum. There's also a question of, in that 50% or 40% of families where we do not identify a mutation, are those truly genetic? Are they perhaps sporadic? Are they perhaps due to one or more low penetrance gene? And what that means is basically one or two changes in the DNA that just increase the risk a little bit, but not sufficient to cause disease unless you have lots of them or other risk factors? Or could it be multifactorial, putting genetic and non-genetic risks together? One of the ways this is played out is in the story of multiple mutations in HCM. So for a long time, we've recognized that about 3 to 5% of patients with HCM have more than one gene mutation. Historically, this has often been identified in people who have very severe disease that often starts in childhood. That's when we start to think, oh, well, maybe both parents actually have gene mutations and pass them both down to that child. Most of these individuals had very severe prognosis or very severe disease with a poor prognosis. What we're recognizing more is illustrated really remarkably in this given family that I had the pleasure to work with. You can see on the legend, this kind of terrible color here is HCM. So there's HCM in the index individual, reminding you that females are circles, males are squares. So this is the proband, her father, her paternal uncle, all had diagnoses of HCM. Genetic testing was started about 15 years ago and consisted of analysis of about 5 genes at that time, which again was the standard at that time. That's all we kind of knew about. And they identified a variant in MYBPC3, which many of you will recognize as being one of the 2 most commonly involved HCM genes. They tested all of the people with HCM and found that they all had this mutation. So for 15 years went on their merry way thinking we'd solved the mystery. They tested these individuals, they tested these individuals. Thankfully, all were negative. And really nothing further was done with genetics until I saw them really fairly recently. And what struck me here is, one, the only person in the family that had been quote unquote comprehensively tested was this individual. And that was really with only about 5 genes 15 years ago. Our new tests have 30, 40, depending on what's going on, sometimes hundreds of genes. These individuals only had analysis of this known gene variant. So not even the other common HCM genes that this individual had. And then the proband was diagnosed young. Partly she was diagnosed young because of her family history, but she had a bit more severe presentation than her dad and her uncle had had. So I ended up ordering a more comprehensive test in her and found a second mutation. And this was a mutation in the gene MYH7, which many of you are also familiar with and recognize that that is the second, one of the other 2 commonly involved genes. This is a subtle missense mutation. And it is a mutation that's been reported before in individuals and classified as pathogenic. We then asked the question of, well, where is this one coming from? Does her dad maybe have this? We didn't think her uncle did because that was one of the genes he had sequenced, but we didn't know if maybe he had it or if it was coming from the mom side of the family that didn't have any known history of cardiomyopathy. So we tested and we found that mom, sure enough, had it. And after she sought evaluation, she's 79 years of age, didn't have a known cardiac history, but after she went to an HCM center, she was actually diagnosed with very mild HCM. And now this changes a lot for this family. This particular mutation probably confers less risk, and we conclude that by all of the data that we have about this mutation in other individuals as well as in this given family. There's no clear cardiac history, and presumably these individuals are all at 50% risk. She has a mild case at 79 and has never had issue. But what changes is the potential risk for the sister here and her children here. So their testing is all pending for both of these gene mutations. And if any of them test positive for either, then care would be recommended long-term. So what this is kind of showing you is not all quote unquote pathogenic mutations confer the same risk. Those 2 variants that I just showed appear to confer very different risk. And we can't chalk it all up to a non-specific term called variable expression or variability. We have to learn more and we have to get better at trying to determine what is the actual risk conferred by a given variant? And that's not an easy task, but it's something that we need to improve upon in order to give families really robust risk assessment. We recognize that our the risk is really dependent on ascertainment. So ascertainment means how an individual family comes to attention. Those historic cases where you have families with extremely severe disease in many people have a different genetic basis, likely a different genetic risk conferred by their variants than somebody who doesn't have that family history, or maybe even just got screened without any symptoms or without any diagnosis at all. And I'll show you an example of that in a second. Then we have to look into also this gene elusive category. So we've called HCM a dominantly inherited genetic disease based on imaging and the wonderful work that Ted and Roselle do diagnosing patients. From a genetic standpoint, it might not all be the same. Some of these individuals have classic HCM that tends to be diagnosed in younger ages. They have dominant inheritance in the family. Those are probably the dominantly inherited HCM single gene causes. But a lot of folks that we see, they're being diagnosed with HCM later in life, maybe their 50s, 60s, or 70s. They don't have a family history. And then the question of, is this really just this, is this really the same condition and we can't find their gene mutation because we don't know all the genes, or is this potentially sporadic disease? Or maybe it's multigenic, multifactorial. And what this ultimately begs the question of, what is the risk to family members? And that's mostly most often from my perspective, the hardest question to answer and the most important question to answer. The proband who has a diagnosis of HCM is going to get fantastic care regardless, but it's very different if their relatives are at 50% risk for HCM or potentially extremely low risk for HCM. And does everybody need those same screening recommendations of having EKGs, echoes, etc., every 3 to 5 years if their family member's disease is not actually highly genetic? This is just kind of actually complicated illustration of how we think of the difference between conditions that are caused by one gene, monogenetic, versus caused by lots of gene variations. What you see in a monogenic disease is that a single mutation causes disease and it's passed down in a family, and it confers a very high risk. So the individuals who have it have a very high risk for disease. Conversely, a polygenic disease is one that's caused by lots of different gene mutations. You tend to see complex inheritance patterns, often on both sides of an unrelated family. And you often see small levels of risk that also there can be some risk from the environment as well. In some situations, these risks are additive, in others they are not. The variability also depends a bit on the genetic testing strategy. So there's lots of different ways to go about genetic testing now, and that last family I showed you was one example of those. So most commonly in HCM, the proband, or the person who came in with the HCM diagnosis, got a gene panel, which is sequencing of HCM genes, and the number of genes on that panel has changed throughout the years as we've learned more. But then once their mutation was found, every individual family member had a targeted test where they just look for that one spelling error in that gene. Now that type of situation, as you appreciated from before, can miss a second hit in a family. And so the question that we're starting to look at is, should actually all HCM patients have a gene panel if there's a known mutation in the family? Previously, we were really limited because the cost of doing something like this was tens of thousands of dollars, and the cost of doing this was a couple $100. But now these tests are pretty equivalent when it comes to cost. And so we question, is it actually better to be more comprehensive? Taking that a step farther, we also have the ability to look at much larger chunks of DNA now. We have about 25,000 genes in our genome, about 35 have been attributed to HCM. If we do a test that some people might have heard, that's called an exome sequencing test. This is a test that sequences all of the DNA that makes protein. So remember going back to those mutations, and you saw that you can change a single amino acid or what have you, but all of those amino acids together make the protein. This exome test sequences all of that DNA, and that's about 3% of your genome. So not that much, but still a lot of information. The advantage of this type of test is that it would look for anything and potentially could identify new genes that caused HCM in the right situation. Whole genome testing then is looking at all of the DNA, even the DNA that doesn't make protein, and that provides an enormous amount of information. It's an area of research. We don't really even have a fighting chance to know how to interpret most of the data that comes from this, but in the future, this will be probably the mainstay as we learn more about this. I do want to point out that, as I mentioned, genetic testing panels or targeted is gotten so much less expensive. There are even some laboratories that have testing available at no cost, though insurance generally covers it well. One example is here. This is the sponsored test that is available at no cost for anybody with HCM. When we think about this ascertainment question, we're starting to see other people who are tested for HCM, and not specifically, but as part of an exome test. And there's a organization called the American College of Medical Genetics, and they're kind of the bigwigs in genetics. And they basically have stated that anybody who has one of these whole exome sequences, if they have a detectable mutation in a subset of genes that are thought to be treatable or actionable, then that information should get reported. So these are often tests that are done in children who have birth defects or in a prenatal setting when there's something severe going on. But if there is an incidental or secondary finding of a mutation in any of these genes, and this includes the HCM genes, there are others, but this is the focus, that information should get reported to the family because it could be actionable. And so this is kind of an example, two contrasting examples of this playing out in real life. So this is a patient who had a whole exome sequence, a 6-year-old who had developmental delay and some craniofacial anomalies. And they had a whole exome sequence that incidentally did not find the underlying cause of their anomalies, but found an MYBPC3 mutation. It was paternally inherited, which prompted this individual, his father, to be evaluated, and he had an absolutely clear diagnosis of HCM. Significant hypertrophy, had arrhythmias, ended up even getting a defibrillator. His mother had a history of HCM that she didn't necessarily recognize, but she was misdiagnosed and followed by EP for her atrial fibrillation, and they just never put 2 and 2 together to say that this was actually a genetic disease until we got these results. So this is an incidentally detected classic HCM family. Conversely, what you're seeing here is similarly a little boy who had whole exome sequencing for neurological findings, seizure disorders, and was found to have an MYBPC3 mutation that was maternally inherited. This 45-year-old woman had a normal echo, no findings of HCM, and the mutation was also inherited from her father, who had a recent history of AFib, which could be reflected of HCM or maybe not, has not yet had further workup. So it's hard to say for sure if he has HCM or not, but you're not seeing anything in his parents either that is highly suggestive of HCM. So one would, if you looked at these two contrasting family histories, one would think that, well, their mutation is conferring higher risk than their mutation, for example. And so just to kind of summarize this piece of it is that the genetics of HCM is increasingly complex and will continue to be so. Some families do have more than one mutation, and that's not always as predictable as we thought. We don't need to have childhood onset of extremely severe heart failure in order to have one mutation segregating. Mutations very likely confer different risks and interact with non-genetic risks as well. And HCM might not always be inherited, and we're working hard to try to identify if there are some subtypes that may not be inherited for the benefit of optimizing screening recommendations for family members. I think the biggest take-home message for me to share with you is to encourage you to follow up with your genetics provider. I think it's very common that folks see us once or twice just in the context of genetic testing and think then it's done. Really, we want you to be checking in with us anytime there is a new change in your own history, a change in the family history, a new diagnosis, or every few years just to check up on your genetic test results and where the field is moving so that we can answer these questions as to whether there might be more tests that are available and appropriate for you at that point. And I will pause there.
Thank you so much. So I decided to, because I'm in the office today doing this, sometimes I do them from home. So I decided to give you a real life presentation on what myosin binding protein C actually looks like. There you go.
Oh, wow.
There's my heart. She just decided to come out of the box and say, hi, buddy. So yeah, you can see the scarring right in the wall of the heart there. Yeah, I didn't warn anybody that that was coming, but it's a thing. So myosin binding protein C is real, and it's something you can actually witness here. So we're going to jump right on. Oh, Ted, I got to get you our new logo, but that's okay. We just changed it so the EKG beat is actually an HCM EKG beat, not an artistic rendition. So we're running a little bit on the late side, so I'm going to answer your questions after the other Dr. Abraham talks. And I have to tell you that I have historically found that Ted was, a lot more chatty than Roselle in previous meetings, but he's been really quiet. I think it's like the girl team here, and he's like, I'm the guy. I'm just going to sit here quietly because all the women will come after me. You're on mute, so unmute yourself, and let's talk about emerging technologies and how we can stop things like this from happening.
Thank you, Lisa. And again, great program. And I'm sorry we're running over, but I'll try to limit the time between this talk and your afternoon cocktail. But we were hoping, obviously, that the HCMA Bighearted Warriors would be right here in San Francisco. And the venue was planned right next to the Golden State Warriors Stadium. So I'm sorry you're all going to miss that. Also, it's so nice to see a lot of old friends and faces on the phone, several of our current panel of patients, and also Mr. Doug, who we remember from our Baltimore days, and not forgetting our conspirator or co-conspirator from Baltimore, Dr. Norma Flores. Good to see you also on the listening list here today. So I'm going to talk very quickly about some technologies, many of which that Roselle and Kate have already gone over, so I'm going to go through them in a little faster. I hope you can see my slides. All good? All right, so thank you. Diagnosis, for diagnostics, imaging is critical, and we do a huge spectrum of tests that people have already talked about. Our philosophy is that we customize it to the patient. We answer a very specific question that will allow us to facilitate a decision, whether we need to do another test or give you the right therapy. And lastly, to monitor response if we do give you the right therapy. These are some pictures that you've seen. This is a classic HCM heart. I hope you can see my cursor, but this is thickening. This is what we call SAM. That's not your uncle, but it's your valve going and hitting the septum. This is SAM again in close up. This is a color picture showing a lot of turbulence of blood going across the aortic valve and a little bit of blood going into the left atrium, which is mitral regurgitation. And then this last one is just SAM at a different level, at the chordal level rather. So this is someone who had no SAM and a marginal thickening. This is someone who had no SAM and a huge thickening of their septum. So again, just a few pictures to show how these hearts look like on ultrasound. As Kate mentioned, we use contrast. This is someone they thought had HCM. We used contrast and we saw that they did not have HCM. This is someone we thought had hypertension and actually ended up having HCM, and we realized this maybe 5 or 7 years after they were being labeled as hypertensive, only because we used contrast. This is someone who, who had a very thick heart and ended up needing an ICD, but without contrast, we thought the heart was half as thick and thought they did not need an ICD. And this last one is an impressive 22-year-old patient of ours who has a huge septum. The septum's about 4 times as thick as a normal septum, and you can see the arteries inside the septum are so dilated that the contrast is traveling inside there. It looks like shooting stars. This is someone, a young 16-year-old with borderline, did not fulfill criteria for HCM, and they had some EKG abnormalities, a borderline looking heart, and we use very advanced techniques, some of them that we cannot analyze with the human eye and have to use computational means to analyze. And in this particular 16-year-old, we were able to use those and found that they had a very abnormal base of the heart, which is where the septum is, or basal part of the septum. And we thought they had some kind of cardiomyopathy, most likely HCM. And then through genotyping, we found a causative mutation, not just in him, but also in his mother. So again, we use advanced imaging where standard imaging and even contemporary imaging looks completely normal. We use imaging that is just emerging and some emerging technologies. You've already seen the MRIs. This is someone with a very large septum, but I want to show you just this person right here whose hypertrophy or thickening was in the mid part. The tip of the heart was actually thinned out and aneurysmal, like a small balloon ballooning out. But most importantly, I want to show you this that's being highlighted here by this circle, and that's a clot sitting in the apex of their heart. And this person needed a complicated surgery, but before that, they needed an ICD and they needed a blood thinner. This is HCM looking at SCAR. You can see SCAR here, and I know Kate went over that. Roselle went over PET scans. This is a 23-year-old with severe chest pain, had 5 angiograms in 1 year, had 4 nuclear tests in 1 year, and was sent to us from Virginia when we were back in Baltimore, and to the psychiatrist at the same time, thinking that she really could not be having such bad pain. And she had severe reduction in blood flow in her septum, where you saw this huge thickening and you see this white blob, which was a scar. So again, using advanced imaging has been very important. Now the magic number, once we know you have HCM, is 30. If your gradient is more than 30, you have obstruction. If it's less than 30 with rest and with provocation, it's non-obstructive. These are slides from the Mayo Clinic where, if you remember, the old style of doing it called a Morrow myectomy, put a trough in the thick portion of the heart. Right now, they do an extended myectomy, and this is some of the myectomy techniques that are used, and it all depends on imaging. Imaging tells them where the obstruction is the valve affected, is the architecture, the structures supporting the valve, which are beneath the valve, are they affected, so that when the surgeon does go in, they can fix all the items that need to be fixed. If a surgeon is not experienced in this and goes in and just thins out the septum or just takes out a little bit of muscle and there's problems with the valve or the subvalvular structure, then they have not done a complete job, and patients will have continued problems after the surgery, which obviously we don't want you to have heart surgery if we can help it. And if you ever need to have it, you need to have it once. This is someone who did not want to have heart surgery and was high risk for heart surgery, so they had a septal ablation. We do an ultrasound with them on the catheterization table. We figure out where their obstruction is, and we see that it's right at the base. Then when we give them alcohol and contrast, we see that, yes, we're going to burn the right area. So we've identified the contributing area or the offending region. We know that the ablation will affect that region, and you can see that their gradient before their procedure, right on the cath table, was 100 millimeters of mercury at rest. And right after the procedure, it was 12. And again, this is instantaneous reduction. Now, sometimes the heart attack or the damage is not permanent, and the gradients may come back in about 6 or 9 months. And in that case, we can make a decision of where to go. There's other ways of ablating. This was obviously using alcohol. Alcohol burns up the artery and causes a heart attack. This is another way that we use a catheter that causes ablation directly by using cold or heat. And this is done non-invasively with ultrasound. This is an ultrasound picture. They go from the chest and push a needle straight into the middle of the septum, as you see right here. And they burn that middle part, which then gets damaged and contracts and removes the obstruction. You can see here how the pressure goes down drastically after that procedure. And you can see here, even the wall thickness goes down drastically after the procedure. But mainly I want to talk about why we need to ditch the scalpel, not have surgery, and save the alcohol for something more fun than an ablation. And this is mavacamten that Lisa referred to and some other folks referred to. This affects the way the heart contracts. So the more bulk the heart has, the more effective this medicine would be. And what it does is it reduces the squeeze of the heart muscle, the enlarged heart muscle, on that critical area sitting right beneath the aortic valve, which is where the gradients are caused. And this was the initial pioneer study done in just 11 or 10 patients. And you can see that the gradient here is the average. It goes down when they have the drug. Within a week or 4 weeks of removing the drug, the gradient goes back up. So we know there's a cause and an effect. If you are on the drug, the gradient goes really down. If you're off the drug, the gradient goes back up. So the drug is doing something for you. Look at this. The starting gradient was 125, the ending gradient 19. As good as surgery without anybody even sticking a needle in your chest. 10 out of 10 patients reduced their gradient. 9 out of 10 were less than 30, which is the normal range by the second week. And even at week 12, 8 out of 10 patients had a gradient less than 30, which is perfect. Sometimes even surgery can't get you there. More importantly, this drug was very well tolerated. For those of you on metoprolol, on cardizem or diltiazem, on disopyramide, they cause so many side effects, especially when you are on high doses. Look at this drug. Almost 60% of the effects were not related to mavacamten, which is the drug we're talking about. Most were very mild, few were moderate, and there was no increase in the biochemical markers of heart damage. The most common side effects were this: headache, nausea, and some people had atrial fibrillation. We were proud and delighted to participate in the Explorer study that just got published. 251 patients in 68 centers worldwide. This is the new drug. And thanks to some of our coordinators who have pictured here on the left, our UCSF site was the highest enroller in the United States and the third highest worldwide. And thank you to the HCMA for a lot of the referrals that you sent us for this study. We were delighted to be part of the prestigious publication that just got published in Lancet less than a month ago. And this is why we were so delighted to participate in this study. This is somebody before we started on the drug. You can see they have a thickened septum, they have a lot of SAM, lots of mitral regurgitation, lots of obstruction. And then I'm going to show you after the drug. If you look here, their SAM, you may not be able to tell, but their SAM has completely disappeared. Look here, this is even more dramatic. See how much leakage there was at the mitral valve? There's almost no leakage left here. Look at the blue flash here. It's barely there. It's so pronounced over here. Also, there's very little obstruction across the aortic valve. This is where blood gets pumped to the rest of the body. What were the actual pressures? This is with rest and this is with bearing down. Before the drug was started, 130, huge, 150, humongous. What about after the drug? Sorry. I don't know why it kicked me out. Sorry about that. I'm gonna
Technical difficulties, please stand by.
What's that?
The technical difficulties, please stand by.
That's right. Sorry about that. Let me see.
I'm afraid to even touch my screen when we're doing these things.
No, I think
I'm afraid to go negative.
somehow I exited the PowerPoint when I was trying to advance to the next slide. So give me 1 second and I'll be back on board here.
Take your time.
Yeah, I'm just restarting the presentation. I should be up shortly. I apologize for that.
So while you're doing that, I'll address a question. Cats have hypertrophic cardiomyopathy too. Why don't we research on cats, not mice?
I'll let Roselle answer the question.
Oh, because mice are a lot cheaper than cats. I think, you know, we usually don't have pet mice. I mean, very few have pet mice, and so people don't mind working on mice. But I think cats, first of all, they're really expensive. The Maine Coon cat you're referring to, who have HCM. And so, and the other thing is, you know, we can genetically modify mice very easily. I think there's transgenic pigs now.
Yeah.
Which the
Our mutant pigs. Our mutant pigs are really good.
yeah,
Yeah,
they're the closest to people. People
Mild
and pigs are really close in terms of cardiac physiology.
So that's why they chose those.
They're expensive, very expensive, and so you need a lot of money to maintain them, study them, and make them. And so right now, there's I think only one mutation pig available, and that was developed at Myocardia.
Right. Okay. So, Ted, we're going to hand it back to you, and Sabrina, we answered your question. Making good use of time, like always.
Can you see my slides?
You're back.
Yeah, so this is what I was trying to show. That is, it went from 130 down to 8, from 150 down to 12. That I think is very impressive. So this is my take-home summary. Imaging is key. Without imaging, really, HCM is going to be very tough to treat and manage. We do echo and advanced imaging, and of course, all the other imaging that I talked about and the folks before me talked about. There are several treatment options. There's conventional medicines, there's alcohol ablation, and there's radiofrequency ablation, and of course, surgery. And imaging and a clinical evaluation determines which pathway, which fork you take in this road. And lastly, there's these new drugs, not the designer drugs that you might have heard of, but the designer drugs that are coming out for HCM specifically. Mavacamten is the one that just ended their pivotal clinical trial, and CYK274, it doesn't have a name yet, but this is a cytokinetics drug that we're actively involved in research trials that's ongoing right now. And I'll stop right there. You've seen our team before, and let us know if we can answer questions. But again, Lisa and HCMA, thank you for having this. And I'm so disappointed that we don't have you right here in San Francisco doing this live.
Soon. We'll come see you as soon as we possibly can. San Francisco.
We certainly look forward to that.
So I had like this nightmare once when I was coming out to see you, and I actually had my heart in the bag. And I thought, what if I actually do leave my heart in San Francisco? Oh, okay, that was a transplant joke. Sorry about that, guys. It's a twisted world I live in. I literally picked up my heart and showed you. So anyway, we're going to go through some questions here. So all of our faculty, please unmute your mic and don't be shy. We're going to do some Q&A here. I can do something different today, and I'm going to throw Julie off on this one. Because we're not streaming through Facebook and we have a relatively small crowd, we could use the hand raise, and we can stop recording when we go into hand raise questions, and we can address the questions right here, just to stop any confusion going to the other room and save a little bit of time because we are running late. So I think we're gonna chill here, and as soon as the general Q&As are over, I will stop the recording, and then we can talk. We'll unmute your mic, so get ready to unmute your mic when you raise your hand, and that's what we'll do to our attendees who are watching. So I'm going to take these in somewhat no order whatsoever. That's what I'm going to do. Let's talk about a genetic mutation in the variant or any information on JPH2 mutation in HCM. Julianne,
Good question. Not off the top of my head. I have actually never seen a patient with JPH2. It's on the panels. There's a number of genes that are on a lot of these panels that are not well qualified HCM genes. So by definition, anything you find in a non-well established gene is going to be uncertain. But I'd have to know a little bit more and in order to really comment.
So that's one of these, stay tuned for more information. And we think when we're doing a panel, we're getting more for our money, but sometimes we're getting confused. Yeah.
Absolutely.
So,
more is not necessarily better, especially when in the hands of maybe community providers that don't know genetics all that well, and they see anything on that report and they think that that's the answer. And so they can get misinterpreted, and that can be very dangerous, especially if used for at-risk family members.
So you're saying centers of excellence matter.
I'm saying knowledge and genetics matters.
Knowledge matters. There you go. Okay, so that question is handled. You got a lot of thank yous. Why is sleep study done, and how to access what, or to assess what, and is HCM and sleep has any relationship? So I think we're talking about sleep apnea, aggravating obstruction. Who wants to take that?
I'll take that. So we know, there's other conditions that can affect your hypertrophic cardiomyopathy. Like we had touched on before, there can be anemias, can also affect your HCM too. And the way so sleep apnea and HCM are not directly correlated. Just because you have HCM does not mean you're at a higher risk for sleep apnea. But having untreated sleep apnea, we know can contribute to hypertension, which is its own risk factor for multiple diseases, but can also worsen hypertrophy and cardiac function over time. And then also AFib, exactly. So if sleep apnea goes untreated over time, you can see actually remodeling of the heart just because of the sleep apnea. And part of that remodeling is the stretching of those atria. The atria can stretch out like balloons. And the more that they stretch, the more that electrical system that's woven in there stretches out too and can malfunction into atrial fibrillation. And again, an increased risk of stroke. So we don't rest our hats on just treating you for HCM. We make sure that we're taking a comprehensive look at you, where we meet you, and also through the lifespan, because people change over time. And so maybe sleep apnea isn't an issue for you when we meet you at 20. So maybe it is when you come back for an annual at 50. And these are the things we're always thinking about to improve your care.
Fantastic. Larry, I'm going to kind of rework your question a little bit here. As genetic tests improve and at younger ages, is the pattern emerging regarding insurance industry's response for risk factor coverage? So I'll pause and then I'll ask our panelists some questions. And I love our masked panelists. I wish we didn't have to do masks, but it does remind us this is being filmed during COVID times. So the Genetic Information Non-Discrimination Act has been law since 2008. This provides protection on genetic information being used against you for the purposes of health insurance access, employment access, and education access. It does not cover you for life insurance and long-term disability. They can use that information to rate your policy, not necessarily cut you off altogether, but they can charge you more money because you're at higher risk than somebody else. So that is happening. Now, when it comes to will insurance providers pay for genetic testing, it's still a bit up in the air and it's still policy to policy. But right now, this very moment, you too, if you have hypertrophic cardiomyopathy, can have free genetic testing thanks to an industry-supported program through Invitae that you can find on the HCMA website. If you don't even have a doctor who can order the test for you, the program can help you get a doctor to order it. Some of our families are related to, they get their care, let's say at UCSF, but they have a family member who lives somewhere else in the country and they don't have a doctor to order it. So if your family member wants genetic testing and doesn't have a doctor, they can go through this program and they can get somebody on the phone to order the test for them and be the doctor of record for the test so that you can have access to the test information. Anybody else have anything to add on that?
I have just a quick thing to add on that. Genetic testing has gotten so much less expensive over the course of a very short amount of time. Out of pocket, if people don't want to do sponsored testing, out of pocket is about $250 for most labs, and most labs are covering family member predictive testing at no charge as well. So that is a motivation. If you have a relative who've tested positive, this is the time to, or if you've tested positive, this is the time to tell all your relatives about it, because they can get genetic testing free and get into, know their status so that they can get into good care.
Fantastic.
Is it international, available internationally, the free testing, or is it?
There are some countries that it is offered in. It does not necessarily go through the same program. So if there's somebody out of the US, I would have them contact the office directly, and then I can put them in touch with the international contacts, because we do that kind of stuff here at the HCMA. Why not? We're helping the whole world. Okay. On that note, I'm going to stop the recording portion of this program. And for anybody wanting more information on the Bighearted tours, to catch another one live, please visit 4hcm.org and sign up for one that we have a couple more coming up for this year. And then next year, they're not going to be so hot and heavy, a few a month. We're going to be doing maybe like one a month, because that would be a normal pace to run meetings like this. But when you're trying to catch up for missed time in COVID, you get them all in the fall of 2020. So I'm going to stop the recording now, and nothing else will change other than the fact that